Hello, everyone, and welcome to the Testing Psychologist podcast. I'm your host, Dr. Jeremy Sharp, licensed psychologist, group practice owner, and private practice coach. Many of y'all know that I have been using therapy notes as our practice EHR for over 10 years now. I've looked at others, and I just keep coming back to therapy notes because they do it all. If you're interested in an EHR for your practice, you can get 2 free months of therapy notes by going to thetestingpsychologist.com/therapy notes and enter the code TESTING. This podcast is brought to you in part by PAR. Hey, guess what, y'all? The Brief A has been updated. The Brief 2A is the latest update to the Brief 2 family. Use the gold standard in executive functioning assessment to assess adult clients. You can pre-order it now. Visit parinc.com/products/BRIEF2A. Hey folks, welcome back to the podcast. I am glad to have you here as always for a clinical episode with my guest, Dr. David Faust. He is an emeritus professor of psychology at the University of Rhode Island and fellow of the Ryan Institute of Neuroscience with an affiliate appointment in the Warren Alpert Medical School of Brown University. He has published numerous books and articles, has lectured nationally and internationally on such topics as psychology and law, neuropsychology, and clinical judgment and decision-making, which is the topic of our podcast today. He is the recipient of various awards and honors in the field, of course. His most recent work with co-authors Hal Arks and Chad Gaudet on clinical judgment and decision-making is intended to provide various tools to increase the accuracy of assessment and prediction. The book has been described by the eminent psychologist and test developer, Dr. Cecil Reynolds, as, quote, the best book on clinical decision-making ever written, unquote. So you will see this conversation is dense. There is a lot of material to take away from this conversation. So don't be surprised if you find yourself rewinding, listening again. There is a lot to take from this conversation. So we're talking about clinical decision making, which is an incredible tool and very useful for us. But I think most of us are a little bit unclear of exactly how it might work. So David and I talk about many concepts from his book, but a few that we cover are why decision research is important for us, what are base rates and how do we use them, the role of overconfidence in clinical judgment, and strategies to integrate subjective and objective data in our evaluations. These are just a few topics among many that we discuss. So again, if you listen to the episode and find yourself wanting to go back and take it in again, I don't blame you at all. There's a lot to take away, and there's certainly a lot of information in his book as well, so go check that out. So without further ado, here is my conversation with Dr. David Faust. David, hey, welcome to the podcast.
Thank you.
Yeah, I am really grateful to have you here. You know, there are a few guests here and there over the course of the year where, I hear about their research or a book in your case, and I reach out immediately because I'm like, the audience needs to hear this kind of material. And you were one of those individuals when I saw the announcement about the book that was coming out. I mean, probably, I don't know what it was, 6 months ago, maybe at this point. It immediately grabbed my attention. I was like, I have to try and get this guy on the podcast. So thank you. Thank you so much for being here.
Oh, thank you for inviting me.
Absolutely. So I'll start with the question that I always start with folks, which is why this? I mean, of all the things that you could care about and spend your energy and time on in this field, why clinical judgment and decision making?
There are a couple of basic reasons. One is I find the subject matter very interesting, given some of the other interests I have in epistemology, methods of knowing, but more so because I was brought up in a family in which service to others was very highly valued. And people talk about science practice models. I think that connection is often not so clear. And so if I were to identify different areas of research and literature in which I feel like I have a decent knowledge base, This is the one that seems to apply the most directly to me to applied work. And so, within the humble limits of my skills, it's a subject matter that I think is important because I think it can enhance care and hence human welfare. So it's my little vote for rationality, but also um, to improve practices to the extent I have something to contribute there that will help people. So that's the fundamental reason or
Yeah. Yep.
reasons.
Sure. Sure. It makes sense. It sounds like a lot of us, it's kind of a mix of personal personal interest and just benefit to the field and where your skill sets lie. It's a nice overlap. So I would love to dive into it. I think there's so much to cover in this area, and we're going to do our best to communicate the important pieces from this topic. But let's start with some background. If you could even start with some kind of definition or operationalization of what do we mean when we're talking about clinical judgment and decision making here?
I think it's just what you think of, Jeremy. We've faced often with very important decisions, often with predictions, either explicitly or implicitly. So whether it's treatment choice, differential diagnosis, treatment planning, deciding whether someone should be tried as a juvenile or an adult, whether a police officer should carry a gun, file it, return, child custody matters, and so on. Psychologists are in the business of decision making and prediction. A lot of these predictions, again, we don't necessarily think of as predictions, they're implicit predictions. And so our careers are filled with many, 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 many decisions. And the purpose of decision-making literature, although I think sometimes perceived, sometimes at the fault of people in the field of decision-making, is there to help us, where possible, sharpen our decisions and make more accurate decisions or predictions. There's an entire body of knowledge on decision-making. Often, psychologists are underexposed to, and sometimes given information that's actually contrary, sounds right, but may be contrary to what maximizes decision accuracy. So it's just what you think of, the day-to-day, moment-to-moment, many, many interpretations, decisions, predictions that psychologists have to make in the decision-making field, while not specifically targeted at psychology. A lot of the research originates from psychologists and applies to psychology, as well as numerous other fields.
Sure, sure. Well, the statement you made about psychologists being underexposed to decision-making research it just rings so true. I mean, I certainly did not have any classes or any portion of a class in grad school that really dove into the decision research. And I'm guessing there are a lot of folks out there who would say the same thing. Does that hold true in your experience, or are there programs out there that are really kind of anchored in this research more than others?
Not too many.
Yeah.
Not too many, actually. And often the value of science is when it conflicts with what we've been told and what we've learned, that maybe it has the greatest value if that science is solid and applicable. I believe that many of the messages given sometimes are counterproductive. So we hear things about it, right? In any training in interpreting, say, test results or that kind of thing. I had a meeting once. It doesn't matter who it's with. They're people I respect highly. And
Yeah.
we independently formulated interpretive procedures for neuropsychology, because the ultimate aim potentially was to put together some kind of principles and guides. And there was an impressive divergence of viewpoint, which is often very, very good, but ended up in a full day discussion. And Perhaps they convinced me somewhat. But in many ways, I think they were open-minded to looking at some of these other principles of decision-making and judgment. I think a little bit sometimes I could name probably many areas in which my knowledge is inaccurate, or other people know a lot more than I do. I think often the things that are commonly said about decision-making in psychology, and maybe this will sound disrespectful, it's not intended to be at all. Quite a bit of that is worth considering in the context of the decision-making literature, which might suggest these are strategies that are effective, but not optimally effective. So I'm not here to tear down anybody or anything. It's not my intent. I've personally found the decision literature very humbling many times,
Sure.
but helpful. So I think sometimes the decision-making principles we sometimes follow are not maybe fully up to date or don't really integrate that decision research. I'll just give you one concrete example. If you go through virtually any textbook or discussion of what you do after you gather data, about how you integrate it, pretty much always hear something not always, virtually always something very similar. The more information you gather, the better. And then the act is of integrating that information, combining it, and often looking for patterns or configural relationships among the data. The average student taking their comps, if they were asked that question and said something like, well, no, I don't do it that way, and I don't think you necessarily should, there'd be a pretty good chance they'd have to take their comps again. However, there are overwhelming reasons to think that that's not always the best approach. Okay, so there are many areas in which I think there's a large and often consistent body of literature that's worth thinking about when we're thinking about what we've been taught, and explicitly or implicitly, about how to handle interpretive practice. And so that's going to relate to differential diagnosis. It's going to relate to judgments about who can live independently. It's what the likely prognosis is, of course, over time, and so on. In that particular example, rather than integrating all the information, because some of it's not going to be very valuable, some of it will be incorrect, is to combine the pieces of information that each enhance decision accuracy, which sometimes is a surprisingly small amount. So I'm just using that as an example. To me, what I found so interesting about the decision literature, so much of it was contrary to what I was being taught, or maybe another viewpoint that was worth considering.
Yeah, absolutely. I look forward to diving into these ideas pretty deeply. I do want to maybe set out a contrast here at the beginning. Maybe it's a contrast. I don't know. We can talk about this, but I conceptualize all of this very simply as it's sort of a conflict between our feeling, so our clinical whatever intuition, let's call it, and actual data and statistics and actuarial info. So I see those as sort of competing and set at odds. I'm curious if you look at it that way, and if not, how you might tweak that relationship, between intuition and data.
Yeah, I think it's a more nuanced issue, personally. So, for example,
yeah,
I just had this discussion with someone about a week ago who interpreted initially what I was saying as this kind of hardcore empiricism, and I'm really a semi-demi, quasi-hemi scientific realist, or about objective, so-called objective versus qualitative data, so on. So, for example, many of the greatest discoveries in neurology, just to use an example, come from single case studies. ideas that are generated in that context. This is also not a debate about qualitative versus quantitative information, because sometimes qualitative judgments are extraordinarily valuable and not reproducible any other way. It's really more a discussion about the integration of information. Also, it's not a debate about predicting objective things per se. So yes, maybe you want to predict how many days in the hospital before being in there is more damaging than leaving, where the risk,
Great
for
question.
example, of infection exceeds the benefits of staying longer. But sometimes what you want to predict are subjective reactions. So if you're predicting the quality of wine, which people now are using statistical formulae and have gotten quite rich off of doing that, there's nothing objective that you're predicting. You're predicting subjective reactions, right? And often that's really of greatest interest. If you want to know whether a doctor may have a good bedside manner, a clinician will relate well to individuals, you're predicting their subjective reactions, but those can be extremely important. Also, you look at literature on clinical judgment, there are times that people are spectacularly correct, and it's contrary to a statistical decision procedure. Or, in many cases, as knowledge does rapidly evolves in psychology, there may not be any quantitative way, and so on. So, also, many of the developments in decision making come from intuition, that's turned into something else. So if maybe in my simplistic way of thinking, it's very important to distinguish between the context of discovery, the old Reichenbach philosopher, that's not quite what he said, but generating ideas, thinking of new possibilities, generating hypotheses. Until you generate a hypothesis, you can't find out. You need a hypothesis to test, figure out whether that might be correct or lead to great insights and value. So there's no substitute for brainstorming, intuition, qualitative observation, and so on in generating ideas. However, it's not always the best way of testing ideas. So I think it's worth distinguishing between a context of discovery and what's sometimes called the context of justification. Many ideas among great thinkers turn out to be wrong because anticipating nature is very, very hard. And integrating complex data subjectively is very, very difficult. If you read Newton's notebooks, there's a lot in there that's wrong. It's just super hard. If Newton couldn't do it, I know I can't expect to do it. So yes. I think it's very, very important to respect subjective judgment processes, human genius that leads us to build things that require that kind of leap of thought and so on. But to distinguish these two contexts, because often the methods that are best for generating ideas are not the methods that are best for testing ideas. And I think a lot of wasted discussion, in my opinion, when people don't distinguish those contexts. So, if you're having a brainstorming session and coming up with ideas, especially with a recalcitrant problem, how do I treat this very difficult client? And if I say, well, you haven't proven that to be correct, and you're not thinking in a rigorous fashion, I think that's a misguided criticism. That is different from saying, however, if we're going to test that belief, the more we can use rigorous methods, so we can be a little more sure that we're approaching the correct answer, that's a different discussion. So there are also occasional incredible intuitive thinkers that come up with things that no one would ever think of otherwise, or have made observations in a clinical context. A lot of people are familiar with Paul Meehl. They often think of him as this super uptight, empiricist. And in fact, he would openly discuss, he was a therapy client for years. He engaged in performing therapy for many years and felt it was a very important way to get a better understanding of the human mind. In his office, he only had two pictures, one of Skinner, one of Freud.
Hmm.
So, um,
That's great.
I said there, I just think these issues are more nuanced. I would be making a mistake if I say intuition, subjective judgment, qualitative data doesn't have potentially a lot of value. And I think it's the contrary to mistake, perhaps the stereotype decision research, as some people have. A lot of people are very opposed to, say, so-called actuarial judgment. And I think sometimes based on misconceptions.
Hmm.
And to say that has nothing to offer, and it's hostile to clinical judgment. I will say some decision researchers who got frustrated about the lack of acceptance or application of their work set this up often as a dichotomy or as a battle. I personally feel in applied work, I'll take any advantage I can get within the bounds of ethics. And,
Sure.
so both bring important contributions to the process.
Of course, of course. Yeah, I mean, we don't have to go too far down this rabbit hole, but I think it is threatening to folks. And I'm, speaking personally as well, that if we get into this idea that we can't necessarily trust our intuition as a great means of decision making, then that's pretty threatening. That's kind of vulnerable. Then it is an existential crisis in a way, unless you kind of take the leap and cross the bridge over to just the acknowledgement or acceptance that, hey, I'm going to be unduly influenced by any number of factors, and I'm just may not be right, and have to settle into the data a little bit. That can be threatening to someone.
Yeah, I think everybody has a right to be convinced.
Mm-hmm.
And so I don't think it's necessarily a leap of faith at all. I think it's something worth considering. That's the way I'd look at it. And it's not a way of replacing practices. It's a way of enhancing
Yeah.
Practices. One of the biggest barriers is sometimes the clinical context is referred to as a wicked learning environment. I don't mean by evil, but very, very difficult.
Mm-hmm.
Because
And is that because, we don't get immediate feedback on whether we're right or wrong? Am I kind
I
of on
think
the
there are about
right
a
path?
half a dozen. I'm sorry, I didn't mean to interrupt you. Please finish.
No, it's all good. Yeah, I was just making a guess. It's come up on the podcast before with, I think, Dr. Stephanie Nelson mentioned the wicked learning environment. I was just
Oh, yeah.
checking to see if I remembered it correctly. Yeah.
There are two things are going on. There are about a half a dozen factors, depending on how you slice them up or group them, that make it harder to learn. So yes, lack of systematic feedback is one. Just to mention a few. Another thing is you don't know what would have happened had you done otherwise.
Mm.
So something that works 75% of the time, that's very good. It's a lot better often than chance. But maybe there's something that would work 80% of the time or 85% of the time. And so that little increment, 5%, let's say, over the course of thousands of decisions, you're getting an edge, and that's important. To learn about the association between variables, you need 4 cells of a covariation table. It's like seeding the clouds for rain. How often does it rain when you seed? How often does it rain and not rain? How often does it rain and not rain when you don't seed the cloud? You have to have those 4 cells generally to learn experientially, to have a comparison. And so it's just very hard. That just generally doesn't happen in clinical practice. Plus, we often understudy normal people in our clinical practices. We have less exposure. So it's also very difficult to integrate complex information, but there's delays in feedback. There's lack of representative feedback. There's channeling effects. Our beliefs channel our behavior, which channel client behaviors. In the old days in the studies, Freudian patients had Freudian dreams, Adlerian patients had Adlerian dreams, Jungian patients had Jungian. Now, that's partially the therapist, but also the framework the therapist is imputing and placing on the individual, and so on. Clients often are hesitant to say something negative about therapists that they depend on. The second component of this problem or issue, which is very, very important. By the way, experience is so salient. Why would you choose a bland statistic over that, right? But
Yeah.
the other thing, which is very important here, is that most of those conditions tend to foster overconfidence. That is a belief that one is more accurate than is actually the case. Now, if you look at decades of literature on clinical judgment, it often is effective, or certainly well better than chance. And that's nothing to turn your head at. If you go from, say, 3 choices and you're 33% accurate by chance, clinical judgment gets you to 60 or 70%. That's a massive
It's pretty good
improvement. It's very good.
Yeah.
Because psychology is very hard. Now, what happens if you're, let's say, 70% accurate? Another method is 80% accurate, or could bring your accuracy up 10%. Okay, but your confidence level is at 85%. You're going to reject that method because studies on the accuracy of these kinds of methods generate information about how accurate they are and are not. So going back to this wicked learning environment, imagine a client comes in, they're worried about their memory. And so you do memory testing, proficient battery, very carefully done. And now imagine 2 situations. And you're articulate, you care. You say, yeah, I am concerned. Some of these results are outside normal limits. It's a little worse than we'd hoped for. And there may be something going on. And in scenario B, exact same scenario, except that falls within normal limits. So people vary in their strengths and weaknesses. Once you get worried about a problem, you tend to hyper-focus on it. You're still performing your job well. Chances are, if you don't have a naysayer oppositional client, and neuropsychologists doing assessments typically don't, right? Either interpretation will be believed.
Yeah.
Even if there can't both be correct. In that circumstance, the frequency of seeming confirmation of judgmental accuracy exceeds the true rate of accuracy. And that also happens when an interpretation funnels a client into a certain behavior. The classic example of that is the self-fulfilling prophecy. The banks are going to fold. I better pull my money out. The banks are okay, actually. It's one of the things that triggered the Great Depression. But then people started pulling out their money and the banks did fold. So our beliefs, by influencing our behavior, often influence our clients' behaviors. And again, that works systematically to make it look like we're a little more accurate or more accurate than we actually are. And so it's not just that there's a wicked learning environment. That is very, very hard. Most of the distorting effects tend to move you towards having greater confidence than is warranted. And so what may be a relatively small advantage, but an important one over time, of certain decision-making aids will be overlooked because they'll seem inferior, because they generate information directly about how accurate they are and are not. Generally, the level of confidence exceeds the level of accuracy. And that's not just in psychology. Most drivers think they're above average. There are studies with physicians in which they're 90% confident when they're 10 and 20% accurate. Most professors think they're funny, funnier than the average professor, and so on. So this is not a form of psychopathology or anything. We're surrounded by environments in which feedback often leads to pervasive overconfidence. So often experience increases confidence more rapidly than it increases accuracy. And now you start to get this disparity. There's an association between confidence and accuracy, don't get me wrong. It's a question of calibration. Because when I'm 70% confident, am I 70% accurate?
Mm-hmm.
What happens is it's often a correlation between confidence and accuracy. So I'm not saying ignore that, but if you're over-calibrated, which most people are in many walks of life, then you'll often reject decision aids that can help you be more accurate because it seems like they're that's the conundrum.
Right. Well, it seems like it would be worth it to talk about some of these ways to recalibrate a bit and bring the accuracy up to the level of confidence, or even invert them a little bit. Yeah.
Yeah.
So
the better the calibration, generally, the better. So it's better not to be over or underconfident, right? To be as accurate about your accuracy as is possible. It's hard. We don't get that feedback, really, right?
Yeah. Yeah, that's true. Well, let's talk about that. So there's a lot to dive into in terms of, what you call normative practices or decision methods. So let's start with base rates. We talk about base rates a lot. I feel like base rates is one of those terms that most of us have heard, some of us have a good command of, and most of us maybe don't. So can we just start with base rates? Like what is a base rate? How do we apply it to our work? Let's just start there.
Okay. So yeah, base rates get defined in different ways. So I'm confused. Of course, it doesn't take much to confuse me. The essential meaning is, and sometimes called prior odds, is simply how often something happened. And it doesn't matter whether you're talking about scatter on 2 IQ tests, bee bites, snake bites, hurricanes, tornadoes, frequency of different psychiatric conditions, outcomes, simply frequency of occurrence. Okay? If you look at the literature on the use of base rates, generally people know nothing but the base rate. 70% of kids in this school are learning disabled. They will use that. The moment you add differentiating or clinical information, we're studying Joe. And maybe just assume for the minute that the problems we're considering totally unrelated to whether someone's name is Joe or not. As soon as you provide case-specific information, utilization of base rates tends to decline. Okay. So
is that,
what's that?
sorry, I just want to clarify a little bit. I'll probably jump in and clarify a lot of these concepts as we go along. But so is that sort of the idea that theoretically, like if we just know that we have a 12-year-old kid coming into our practice for an evaluation, we're a lot more, I don't know, willing to accept the base rate, let's say, for a diagnosis of autism before the kid comes in, than once we meet the kid and gather a bunch of clinical information. Is that what you're saying?
Pretty much. But if what you know about the kid coming in has absolutely no relationship, let's say, the diagnosis of autism, like they like kids' sneakers, whatever. But even that kind of information will move people away from the base rates. In fact, pretty much anything you tell anyone about. Let me put it this way. In one of the surveys we did, one of the studies, if you ask individuals, have they heard of the base rates? Did they use them? It's kind of yes. But if you ask them a question like this, are there times in which base rates are far and away the most accurate diagnostic indicator? People almost never say they strongly agree with that.
Mm-hmm.
But in fact, for a fair number of decisions, and maybe many, a base rate is the single most predictive variable. And I can give you some examples of that. People don't think of it as a diagnostic indicator because in a way it's very bland, right? And it's just a stupid number. And what does that really have much to do with anything? But
Sure.
what we learn is when you look at sensitivity or specificity of a diagnostic method, it's usually in a study in which half the people have a condition and half don't. Okay?
Okay.
So the base rate's 50%. When the base rate's 50%, the base rate does you absolutely no good.
Right. Yeah, that
It's
doesn't
just like
seem
flipping
helpful.
a coin.
Yeah.
What if the odds were 99-1? Let's just assume that, okay? And sometimes that happens. So maybe we're trying to identify dissociative personality disorder, or it's many guises. And let's just say my setting of interest occurs 1 out of 100 times. If I play the base rates, which is guess what's most frequent, which in this case is the non-occurrence, I'm going to be right 99% of the time. So all else being equal, for a test to do better than that, it's got to be more than 99% accurate.
Yeah, that's tough.
And there are instances in which the base rates are even higher or lower, very high and very low base rates. If you have to make a dichotomous decision, does or do not have this condition, will or will not make a suicide attempt, and so on. Often they're way more accurate. And so, or if you're just trying to calculate probabilities, the probability of a suicide attempt, or again, in a dichotomous decision, hospitalize or don't hospitalize, and either defer to the base rate or combine it, right, with the diagnosticity of signs or indicators. What I mean is to combine the base rate, if it will help, with, say, results on some kind of test or index. So one of the questions you can ask is, do I know what the base rate is?
Sure.
And if I know what the base rate is, and I have to make a dichotomous decision, say hospitalize or don't, or refer or don't refer, or whatever it is, if the base rate and the test point in the same direction, there's nothing to resolve. If they point in opposing directions, and you have to choose one or the other choice, you can just go with the stronger indicator. If the base rate is vastly more accurate than the test, why in that circumstance would you go with the test?
Great question.
I was involved in a situation at a metropolitan hospital. It had about 100,000 patient admits a year, medical hospital. 1 to 2 people per year were sadly jumping out of windows. I mean, horrible. So hospital administrators came down to the psychiatry department and wanted help. How do we identify these individuals? Which, much to their credit, not only was it bad PR, but of course it's a horrible credit.
Yes.
And as someone put forth the following proposal, which is, we have this screening approach. I'm not sure I agreed with this statement, but they said they did anyway. That was 90% accurate, 10% false positive. So on the face of it, sounds great. Okay, let's assume for the minute in the present year we're considering there was 1 suicide. Okay, which I don't mean to reduce the value of human lives to numbers, and I don't. Obviously, you want to do everything you can to avoid that. If you use a method with 100,000 patient admissions that is a 10% false positive rate, you will misidentify 10,000. Now, if you think of the cost of, first of all, testing 10,000 people, what do you put in their medical records? They're at risk, and so on and so forth. And again, not reducing human lives to numbers. If you took the money that would have cost, which as you can imagine was in the millions, you could save hundreds of them for that. So if you consider all life of equal value, from a utilitarian perspective, I'm not sure that's a very good solution, but no one had raised the problem with the number of false positive errors and the consequences of that. So I was a little punk intern, and I was sure as hell not going to speak up in that context. But contacted the administration later at great risk.
Okay.
And,
Yes.
Went through this.
Mm-hmm.
And then what they had not considered was safety screens. For Windows, safety screens are expensive.
Mm-hmm.
Cheaper than the screening. And if you put them starting on the second or third floor, because most of these are impulsive, momentary acts, you can prevent that pretty much from ever happening.
Yeah.
So much less expensive and more effective. Because even if you identify someone, you're not necessarily going to prevent it anyway. And you avoid 10,000 errors. That's simply a base rate problem. 1 out of 100,000, you're just not going to come up with a method. It doesn't mean in certain contexts you wouldn't screen anyway. Military came to me later in my career with a similar problem. But also the intervention involved dedicating more resources to mental health issues and trying to inculcate peers with this idea that you're doing people a favor to hear something alarming, to report them. Anyway, it gives you an idea of the profound potential impact of base rates. And when you're making dichotomous decisions, and base rates are much more accurate, you don't have to go through the other stuff generally. In estimating probabilities, so people think of validity as a fixed rate in some sense. I understand it varies when you go from person to person and so on. But if you get, let's say, an 80% accuracy rate, that's going to be altered by the base rate. So if the test says 80% yes, but the base rate's 1 in 1,000, the probability is going to be about 1% or 2%. And so on. So when it's not just a dichotomous decision, but you're trying to estimate probabilities, the base rates can alter that probability profoundly, twofold, fivefold, tenfold, 100-fold. And so the best estimate of probability in that circumstance is to combine valid diagnostic signs and indicators with base rates. And, when you check out at the supermarket, you don't eyeball the heap of purchases, as Paul said. Say to the clerk, well, it looks like about nowadays $210.11 worth. What do you think? It's a time when you just can add up the numbers. And so to get accurate probability estimates, you may be able to do that in your head, but it's just a few simple calculations and you're all set. And so at every level, knowledge of base rates, or at least good estimates, can do a lot to enhance diagnostic and predictive accuracy. And one last quick thing, and I used to do rounds with the neurologist when I was an intern. And for an intern, I held my own. But there was only one reason, only one. It had nothing to do with intelligence, nothing. I just knew when they presented, they usually are going to present ambiguous signs, trying to teach you something. But sometimes the base rates are very different, right? The diagnostic possibility said always go with the base rate. And I had one of the neurologists, I don't know, about 3 months into the rotation, asked me if I was some kind of weird freak. Of course, the answer is yes, but whether I had originally been trained in neurology, this sort of thing.
Yeah.
And I told him I was just playing the base rate. And he actually did not believe it. But that's true. So it didn't take any particular smarts, honestly. But if they're saying PICS versus Alzheimer's, and, Alzheimer's is 10 to 20 times more frequent, I'm not going to be right every time. But if the signs are ambiguous or even tend to favor PICS, they better damn well do that in a strong way before they're going to overcome the base rates.
Yeah.
So I think base rates are a good example. That shouldn't threaten anybody, I don't think. Um,
Yeah.
it's not that complicated to apply. It's not dispositive. There are times to bet against the base rates. Sometimes they're not helpful at all. Sometimes the base rates are not very accurate. But when you have them available, and there's much more base rate information than people think, they're just a handy tool to assist us.
So let's talk about that. Like it sounds like it's going to be helpful for us to know base rates. Like that's just a place to start essentially in good decision making. Just know the base rates. That's going to have a lot of value.
Yeah, you don't have to memorize it.
Sure. Yeah, you can look them up. I mean, so my question though is, when are they less helpful? And like you said, like when do you take other information into account? Like when is it reasonable to question or look for other options aside from base rates? Let's take a break to hear from a featured partner. Y'all know that I love Therapy Notes, but I am not the only one. They have a 4.9 out of 5-star rating on trustpilot.com and Google, which makes them the #1 rated electronic health record system available for mental health folks today. They make billing, scheduling, note-taking, and telehealth all incredibly easy. They also offer custom forms that you can send through the portal. For all the prescribers out there, Therapy Notes is proudly offering e-prescribe as well. And maybe the most important thing for me is that they have live telephone support 7 days a week, so you can actually talk to a real person in a timely manner. If you're trying to switch from another EHR, the transition is incredibly easy. They'll import your demographic data free of charge, so you can get going right away. So if you're curious, or you want to switch, or you need a new EHR, try Therapy Notes for 2 months, absolutely free. You can go to thetestingpsychologist.com/therapy notes and enter the code TESTING. Again, totally free, no strings attached. Check it out and see why everyone is switching to Therapy Notes. Y'all know that the Brief 2 has long been established as one of the leading forms for measuring executive functioning in children. Now comes the latest addition to the Brief 2 family, the Brief 2A. This update will allow you to use the gold standard in executive functioning to assess adult clients. And you don't have to wait. It's available for pre-order right now. Learn more at parinc.com/products/BRIEF2A. Let's get back to the podcast.
Yeah, that's a really good question, Jeremy. So sometimes you just don't have base rate information. It's one of the reasons why people who want to batch clinical judgment are making a mistake, because often that's what you have. And sometimes it's pretty damn good. Other times there are serious reasons to question the accuracy of the base rates. And the margin of error might be very large. So things that people don't want to report. And what's the incidence of child abuse? Well, it's really hard to get a handle on that. There's stuff floating around about the frequency of malingering in legal cases. And there are a lot of reasons to think. First of all, the estimates vary enormously. So how much is that going to help you? And often there's not much of a solid basis for it. So as a couple of rules, general rules of thumb, in general, the closer base rates are to chance frequency, 50-50, the less useful. Okay, so if I know it's a dichotomous choice, the base rates are 50%, they're not going to be very useful. There's some exceptions to that, but that's a good rule of thumb. However, to the extent they deviate from chance in either direction, the more useful they are. Because if you're going with or being assisted by knowing the most likely occurrence or non-occurrence, that can be very, very helpful. So if I go back a number of years and was guessing the likelihood my daughter would be back on time before curfew, it's a pretty safe guess that would not happen. I'm kidding. My daughter's actually a very responsible person. But it's a deviation in either direction. If the base rates exceed 50%, especially when they're getting up into the 80s and 90s, then you'd guess base rate events. So if you're in the Olympia Peninsula in Oregon and you want to guess whether it's going to rain the next day, just say yes. But if you're in Death Valley, just say no, because their base rates are low, so you'd guess non-occurrence. So one very important rule of thumb in deciding whether to use base rates or to consider them is how much they deviate in either direction from 50% likely. Okay? It's not an ironclad rule of thumb, but it often works pretty well. And sometimes in psychology, we deal with very high and very low frequency events. And with rare exception, the base rates will be the most accurate predictive variable.
Yeah.
You have to get over this idea of variable prejudice. Intuitive judgment is never useful. Or I just don't believe in projectives at all, so I'd never use that. Does that mean every single projective indicator has no value? And so on and so forth. So you just go with whatever is most helpful within the bounds of ethics, and sometimes that's a bland base rate. But the other thing is you have to balance the use of base rates. Let me back up a little for a second. If a variable is invalid, you don't use it.
Sure.
If a variable doesn't beat the base rates, like say a test result, diagnostic sign or indicator, aside from situations in which you'd combine it with the base rate, sometimes you're just going to bet the base rate may be more accurate, but you may want to bet against it. If we're predicting suicide risk, even if there's a 5% risk, the base rate's low, but the cost of a false negative error is so great so that you're always looking at utility as well and the benefits and costs of false positive and false negative errors. The base rate validity is almost dispositive. If something's invalid, why would you use it? You have strong evidence or has almost no diagnostic or predictive value. Other diagnostic signs and indicators, including base rates, can be pretty probative, but you always have to examine the potential costs and benefits. If you think someone can live alone and won't burn down the house, but you're only 40% sure, that is nowhere near.
It's not great.
Near enough. Yeah, that's right. I just want to mention one other thing, which is there's a lot of base rate information available. It's not going to be listed as a base rate. All outcome studies, for example, generate base rates. How often do people get better from concussion or mild head injury? What is the typical period of recovery? So epidemiologic research gives you base rates for different conditions. So one of the things, there's sources. McCaffrey has a text out on sources of base rates. We try to cover in our book various. I'm not trying to plug the book. I'm really not. I'm one of the least self-promotional individuals, but we have stuff on sources of base rates, and it's all over. But you just have to think of it. If in neuropsych, we often use a very narrow condition, like how often do people have X number of abnormal results? It's a generic term, frequency of occurrence. And when you think of it that way, frame it that way, there's base rate information all over the place.
Right. Well, yeah, I want to make it super concrete and think about diagnostic base rates or, occurrence of different diagnoses. Would you consider those high and low frequency? I mean, in the majority, I guess anxiety and depression are maybe, higher than 10%, but I think the majority of our diagnoses, right, are occurring in less than 10% of the population. Like, would you consider those useful base rates?
Certainly the ones that are very low and that don't involve dangerous conditions are extremely useful. But the other thing is that generally you're not using base rates for the general population. Okay, if you have someone who's a multiple murderer, you're not going to say in the general population. So it's important. And your question is very important because you're right. Most are low frequency conditions. relatively speaking, and therefore it wouldn't be an irrational position to say, I'm going to miss every condition that's present pretty much. I defer to the base rates. Now, you may want to combine it with the diagnosticity of signs and indicators, right? But
Yeah.
if you narrow, it changes things. So, for example,
Hmm.
suppose the differentiation is between global general anxiety disorder and PTSD or something like that, PTSD and post-concussion syndrome, because
Yep.
base rates are very helpful in differential diagnosis. So the rule of thumb with base rates is to use the narrowest applicable base rate. And
Okay.
what I mean by that are indicators or characteristics or attributes that influence the base rates and that apply to the person you're seeing. So, for example, if you're thinking stroke and you're seeing a 70-year-old, age is going to make a difference. And if you're seeing a 70-year-old who has horrendous dietary habits and who's had a stroke, okay, that applies to what I was saying because you're narrowing in relationship to change in base rates for the condition you're looking at, right? In other words, if they love purple socks, that may apply to them, but that's probably not going to change the base. So if you're looking at a knee injury and you're looking at an NFL player versus, 6-year-old child, so narrowness defined by variables that change base rates and that apply to the person. I may have all kinds of information about base rates with adolescents, but if I'm seeing an adult, it doesn't apply.
It doesn't matter.
So
Mm-hmm.
as you can narrow, now you're dealing with very different base rates, often higher, of course, but also when you're trying to choose among, say, 2 or 3 conditions, they may have themselves very different base rates. Okay. And in that case, going back to pics versus Alzheimer's, if you pick someone off the street, they're going to have neither usually. But if you're picking 75-year-olds who've been in repeated car accidents, who've got a genetic vulnerability, it's had a history of 2 major head, you narrow. And narrowing changes base rates and also in performing differential diagnosis, picking from among competing treatments or looking at outcomes. Now you're in a different situation where the base rates, it's more likely base rates will be helpful to you. And so
Yes.
this is a very common misconception. There's a well-known author. They say, see if it's forensic versus clinical context. If your practice is all forensic, assuming, say, a base rate of 30 or 40%, use that for frequency of malingering. It's clinical, use a much lower base rate. If half your clients are clinical, half are forensic, pick the average. But that doesn't make any sense. If you know it's a clinical case, use the base rate for the clinical case. Because if you average, you're going to increase false positive error, right? And if for the forensic case, if you use the average, you're going to have more false negative errors. So that principle of not using general population base rates, but base rates that are narrowed on variables that are relevant and change base rates. That's the idea, and that just changes the whole.
I appreciate that. Yeah. I mean, base rates are super important and, like you said, often overlooked, I think, but they're a big component of good decision making. I would love to talk about more strategies to help us with our, as you say, clinical prediction and diagnostic accuracy. I think a lot of us are interested in that. So, what other components might be involved here, and how might we walk through and enhance our diagnostic accuracy specifically?
So the other sort of broad method I'll mention is increasing use of properly validated statistical decision methods. Never a popular topic. and then maybe talk about some other related strategies.
Great.
So, in my opinion, for what it's worth, this is one of the most misunderstood issues in psychology and neuropsychology.
Mm-hmm.
I'm not sure why. I'm not sure why. So I want to take a step back and define what these methods are.
Yeah.
Clinical judgment and statistical decision making.
I think that'd be helpful. Yes. Because I'm not sure people even know what you mean. Yeah.
Fair enough. Yeah. Just to initially dichotomize, you can make decisions or let's talk about interpretation of data. So that's the heart of the issue. You can do it in your head through whatever means you choose. So if I'm a neuropsychologist and I'm looking at test data, I may have a vast research knowledge. I may know about certain decision rules and so on, but ultimately the data integration is done in the head.
Yes.
And through clinical judgment, you could call it impressionistic judgment, subjective judgment. People may be, I hope they're not offended by those terms. So that's one approach. At the other end of things, you take, it's defined by two things. Number one, same data, always same interpretation. So if you will, automated, pre-specified, based on empirically established relationships. I hate to use that word empirical because all it means is by observation. But anyway, I will use it for now. So if I'm a baseball scout and I'm trying to pick out a ball player, I may know a lot about them and ultimately put that information together in my head and reach a prediction or evaluation. Alternatively, I may have 5 variables, whatever they are, and it can be qualitative, like how much heart do they seem to have? When you develop statistical decision procedures, anything is a fair candidate, and often qualitative indicators are very important. I just would have to code it. And then I see whether, when I combine that information in some way statistically, it might just be adding them together, looking at configural relations or whatever. If I look at them statistically, how well do they predict? Typically, if I'm doing this properly, I'm getting rid of the variables that are non-predictive, getting rid of the variables that are strictly redundant, just the same measurement twice, basically. And then I have to cross-validate because, as we know, multivariate statistics capitalize on chance. And a study on statistical methods of decision-making that don't cross-validate or validate really is a better statement. Just should throw them out the window. So then the question is, given a fair horse race, both methods, clinical judgment, statistical method, are given access to these same information. How does that turn out if you have both methods predict? What you have to do with qualitative information is code it in some way. So let's say I have a feeling patient strikes me as odd, which actually turns out to be a pretty good diagnostic indicator for kinds of schizophrenic conditions. So it's not an argument about type of data, okay? And this is almost always confused. It's an argument or debate about how to integrate or interpret information.
Yes.
Okay, so lots of statistical decision methods incorporate qualitative impressions, but only to the extent they turn out to be helpful. And many of them do incorporate qualitative information, okay? And what happens when both methods have the same information? So this has been going on for about 7 decades now. I would say there are 300 good quality studies.
Okay.
And when I'm eliminating studies here, and I'm not just the one who does this, many of them are studies in which the statistical decision-making method has an unfair advantage by not cross-validating, okay? So no fair researcher would go in. And if I could just say this, I think like most people, all of us are passionate about trying to find answers that help us do our job better. So are there some people who go into this literature with biases? Yeah, sure. But Many of these decision researchers are very, very invested in enhancing accuracy.
Sure.
So here's the outcome of the study.
Okay.
Initially and over the decades. Number one, often misstated by the advocates of statistical methods, this drives me crazy, used to drive Paul Meehl crazy. They say something like statistical methods always beat clinical methods. That's nonsense. It's not true. A statement to that effect is counterfactual. Many of the studies, less so now, generate ties. And so it's inaccurate, it's unfair, and it's demeaning to clinical judgment to say statistical methods are always better. That's wrong. It should not be stated.
Okay.
Where there's a difference, then depending on how you count, about 95% of the studies, give or take 2 or 3%, either way, where there's a difference, the statistical methods do better. Sometimes that edge is very small, 3 or 4%. Sometimes it's substantial, 10 and 20%. So if, say, clinical judgment is starting at 60, 70% accurate in a study, again, way better than you might do, just by tossing coins.
Yeah.
Say we have 30% error. If you improve that by 10%, you're reducing error by a third. If you increase by 15%, you're cutting it in half. And over the course of a career and hundreds, thousands of decisions, that edge makes a real difference. And if you just classify all the studies into level of judgmental proficiency, I think the simple take home is that if you have a category of good or very good, there are a considerably higher percentage in the statistical decision method that fall within that category. And if you look at poor, chance or even below chance, systematic bias can lead to below chance performance. That's rare in both cases, but about 3 times more often in the studies on clinical judgment. So it may be a difference of 6 and 18% or 4 and 12%. But, obviously that's very, very important.
Absolutely.
The original reasons for rejecting those studies or questioning them, which were very legitimate, maybe not the best clinicians. You have people predicting grade point average. Really, psychologists don't sit around worrying about grade point average. So they're given deficient information. All those things are very, very reasonable questions. What's happened literally over the decades is a couple. When I first heard Paul Meehl lecture, he was saying he was trying to do the new edition of his clinical stats book, his little classic book. And he said, it's too boring. I can't stand it. I'll never do it. Because he said all the studies come out the same way, which is ties or, these advantages.
Okay.
And there's a lot of truth to that. So what's happened is many of these very reasonable questions have been tested, the experience of the clinicians, the amount of information they're given, and so on. Judging familiar tasks, having them identify the tasks, making sure they're of high clinical relevance, suicide risk, presence of brain damage, and so on. None of those things generally seem to matter very much or at all. Freely calling exceptions, countervailing, same thing. The other thing is if you trace that literature across decades, literally decade by decade, only crazy people do that. I'm one of them. You do see a trend towards increasing accuracy with the statistical methods where it's studied more. Prediction of violence, for example, is a really good example, relatively short term, and other things of that nature. Suicide prediction over shorter intervals, again. And if you look at, it's going to be disturbing to hear, clinical judgment over the decades, some exceptions. Neuropsychology potentially has some of those exceptions. stayed about the same. It has stayed about the same, which shouldn't be happening really because our research knowledge is so much better. Psychology, like many of the more advanced sciences, it's not yet there, but the turnover of information is about 5 to 7 years. If defined by 50% of the citations become less relevant, that's a phenomenal rate of growth. It's of tremendous credit to psychologists. It promises, now I've given a talk, marked accomplishments, even brighter future, bright past, brighter future. So many indications of advances in our field that are so promising. I tell students this is a really good field to get into,
Yeah.
because it's in the process of being revolutionized. And but
That's a good way.
subjective judgment stays about the same. And then also, when you look at sources of information, as more information is provided, there's valid information for clinical judgment purposes, the actuarial edge grows. If you add interview, again, a disturbing thing to hear, to testing, I'm not saying you shouldn't. Interview generates valuable information. There is no question about that. And if you combine interview and testing through statistical methods, it often will enhance accuracy. I think that's a clear issue. If you do it subjectively, though, on average, you will not improve accuracy. And in fact, you may decrease it. An invalid variable or a weaker valid variable added to the mix will diminish the impact of more valid variables. Valid variables can decrease accuracy. One of the reasons why you shouldn't integrate all the information, should combine all the information that enhances accuracy. What happens with interviews, because they're so dramatic and salient relative to a bunch of scores, is in most of the studies, and this is clearly true in industrial psychology, adding unstructured interviews, flexible interviews to testing overall tends to decrease overall accuracy because of dilution of valid variables by, people aren't doing this on purpose, including in this sort of subjective integrative mix, variables that are either not valid but appear to be, illusory correlations is a thing, and variables that are valid but weaker. So across conditions, if you're just to rate accuracy, testing plus interview interpreted statistically is best. Testing alone, interpreted statistically second best. Interview alone, interpreted statistically next best. Tests alone, interpreted clinically next best. Test and interview, more can be less, next best. Interview alone, i.e., the average psychiatric evaluation, least accurate.
And just to bring
If you look at the frequency with which methods are used across the country, it's a little scary.
that, I think, is a really illuminating point. I mean, because we hear a lot that the interview is the most important part of the evaluation, and folks rely on interviews, myself included, a lot, quite a bit, heavily. So I think just one more time, I just want to put a fine.
I mean, if I could just say, interviews are they're essential. They generate very useful information.
Yeah.
The difficulty is it's very hard for the human brain to either realize what's really impacting our judgments.
Mm-hmm.
And it's very, very, very difficult, given all the noise in our data, conflicting indicators, the limits of the human mind to handle multiple lines of evidence simultaneously that often aren't even aligned together.
Right.
But it's not because it doesn't generate useful information. It's almost like that discovery and validation. It's subjectively incorporating it together is very, very, very challenging.
Right.
And that's where that overconfidence is a problem.
Right. So that's why, I want to revisit and put more of a fine point on how do we do that? How do we integrate this information statistically versus clinically? Like how does one integrate interview data statistically when it's so tempting to do it, subjectively or clinically, like you said?
Well, the other thing, Jeremy, to keep in mind is that if you ask individuals what influences their judgment, just like anything else, we don't generally have very good insight. So, for example, this started with research setting up sock displays. They asked people what makes them want to stop and shop for socks. And so they listed a bunch of variables. And then the researchers varied a variable at a time.
Okay.
Where was in this store, the color, and things like that.
Uh-huh.
And it turned out that self-report often had little correlation with behavior. And so this started a huge line of research on what's called subjective versus objective cue utilization. There are lots of studies in psychology and psychiatry, fewer in neuropsychology, unfortunately. So if you ask people who are reporting sincerely, what variables do you take into account? And, they may specify, psychiatrists may specify 8 to 10 variables.
Sure.
These are all very important in judging depression. And then you set up cases, I can't go into this too much now, in which you vary one at a time. So maybe psychomotor retardation, present versus absent, all else the same, and so on.
Yeah.
You can actually study the impact of those variables on diagnostic conclusions. Those studies show a number of very, very important things. One is subjective belief about the impact of cues, of what we weight heavily, often does not correspond well with the impact of those variables on our decisions. So things that people think really influence them may not really influence them much at all. Things that people think don't influence them, maybe gender or race, and I sincerely believe in my heart, may influence them a lot. And usually it's 1 or 2 or 3 variables that account for most of the variance in decisions. Not 20, not 50, not 100. John Exner said 1,000 wasn't enough. 1 or 2 or 3 can reproduce their decisions most of the time in most circumstances. So it's very sobering, but it's actually very helpful because, what did Gandhi said? I'm aware of my own limitations. Therein lies all the strength I possess, because it's a rare thing for a person to be aware of their limitations. And we're fine telling our clients that, it's, hey, don't get uptight about it. So that's a shocking line of research. I never in a million years would have guessed that.
Yes.
But that's why we have all this help. The use of base rates. Statistical decision procedures, if properly developed, are not going to include variables that are not predicted, and so on. And so the message here is don't trust your judgment. Again, if you go back, clinical judgment usually is pretty decent and sometimes very good.
Sure.
There may be some people who are exceptions. However, if you believe factors of learning almost invariably create overconfidence, and secondly, we don't have great awareness of the variables that truly impact our judgment, then that just calls for a little shift, in the way we go about some of these. Yeah. So, for example, going back to what you said, it's not a terrible thing to ask a question to yourself. What might be, if I'm aware of, say, a statistical decision procedure, take something as Bob Heaton's general deficit scale. Just not familiar with it. It's an old decision rule. Bert Russell came up with others, and they exist in psychology quite a bit, actually, and in neuropsych. What is the best reason I can generate not to ignore that? That is, what is the best reason I can think of why that might be correct? And then if you're going to countervail based on interview impression, then you might ask, what's the best alternative reason? Or, anyway, if people are overconfident, if you're thinking of reasons why you might use a decision or why, your conclusion might not be correct, you're making less. We look for confirming evidence often, primarily. We bring to mind disconfirming evidence, considering the opposite. It can bring confidence levels into better alignment. And then people won't bet against statistical decision rules as often. And so it doesn't mean they never should. Of course, you have to at times, but that's a whole topic. That's the hardest. That's the hardest one. And then also because, sadly, if you look through psychology, there are almost no studies on incremental validity. That is, what is the maximum combination of variables?
Mm-hmm.
And there you'd include every possible source of information, but primarily testing and interview, right?
Sure.
Okay. How else would you identify what's an optimal interpretive practice without studying it? The beauty of science is not only to test our belief, but it helps us. People have sometimes misconceptions, and a lot of scientific debates take a long time to resolve.
Yeah.
We could be dealing with some little issue in digestion, and it can take 20, 30, 40, 50, 70, 100 studies. So how many studies are there in the MMPI? But how many studies are there on incremental validity, diagnostic and predictive practices? Because the overconfidence, and I think sometimes, if I can be so bold as to say, underappreciation of the strengths, but also, our boundaries in decision making.
Yeah.
I think are often just, people don't worry about that very much. There are lots of ways of approximating this, okay? And I know we don't probably have a lot of time to get into it. So I don't want to leave with a doom and gloom message. I want to say that there's a lot of base rate information available. There's a lot of statistical information available, hundreds, thousands, okay? There are 300 good comparative studies approximately. But think of it this way, if in 95% of the cases when there's a difference and between statistical and clinical judgment, and statistical does better, you don't need comparative studies everywhere. You always have the option of using subjective judgment. But if you go into any journal in neuropsych, about a third to 3/4 of the studies are going to be on statistical analysis of prediction of something. Disease 1 versus disease 2, development of dementia, on and on and on and on. Neuropsychology is amazing for the number of direct statistical decision rules that have been generated. They're just not identified as such. So if you realize the prior odds of beating those through subjective judgment isn't great, you always have that for almost any diagnostic and predictive task you could think of in neuropsych. There will be statistical decision methods. There just won't be comparative studies, but it's a pretty good base rate. The ones that look at optimizing incremental validity, there's some out there, but shockingly little. Problems taken for granted are often problems not studied. And I hope and believe, and especially now with just the great databases, we could easily be studying this more and make very rapid progress in doing a little bit of a better job there. So, but Jeremy, really quickly, some of the ones where, as we're waiting for Godot, I guess you'd say, I have a few sort of other tips or rules of thumbs if you'd like me to go over them.
Great. Yeah. I know we're getting close time-wise, but I think it'd be helpful to close with some tips for folks.
Okay, sure. So if you were to ask what's the best predictor of decision accuracy, it's meticulous adherence to the best validated methods. That's it. Okay? It's not years of experience.
Yeah.
It's often not brilliance. But both those terms are essential. Meticulous, taking great care in practice.
Yes.
Adherence to the best validated methods. So that's the key. Second, insight alone doesn't do much. You can be aware of the decision literature. You can be aware of racial biases.
Yes.
You need to equate those. You need to take active steps.
Yes.
Because given both overconfidence and lack of insight into what most influences our judgment, just telling yourself not to be biased or to do differently by itself is not enough. Okay?
Yes.
Consider the opposite is a very simple little strategy that has a lot of application in my notes. But What's the strongest piece of contrary evidence to the decision I've made? What is the best reason I can think of for an alternate diagnostic possibility, for following, not countervailing, a statistical decision rule? Because we tend to search for confirming evidence, identifying. We then pay insufficient attention to disconfirming evidence. That tends to feed our overconfidence. And that doesn't always work, but you'd be surprised how often that improves things.
Sure.
Anything that helps with meticulous practice, neuropsychs are often good that way.
Mm-hmm.
You can build in redundancy. Double keyboarding, it's a pain, but that will reduce keyboarding errors to almost 0%. For tests that depend highly on configural analysis, scale A being high, B being low, and so on, even a couple of keyboarding errors can actually, especially with scales that have few items, like some of those MMPI RF scales, can devastate pattern analysis. Pattern analysis is highly unreliable because it all depends. I won't go through the mathematics of that.
Yeah.
But some of the strategies occasionally used in neuropsychology have a reliability approaching 0. Yeah. Because the more you look at complex relationships, the more vulnerable they are. Lack of reliability is not even additive. It's often exponential, the more complex. I'm a big fan of checklists.
Okay.
It's surprising how effective they are. It's one of the reasons, I gave you an example of one of our checklists. So that's free for anyone who wants it.
Yeah.
If you want to use it for kindling wood, that's fine too. But it's shocking how helpful that is in many, many branches of healthcare. Recognize the limits of experience. Experience can increase accuracy. It will certainly increase proficiency in certain areas, especially in certain kinds of learning environments or with procedural knowledge. I wouldn't want someone giving their first IQ test, but there is a point of diminishing returns. And the saying, experience is the best teacher, is not what it stands for. Franklin is also often credited for that. The Old English dear meant cost. And the full statement is, experience is a dear teacher, i.e. often costly, and fools will learn from no other. We have a lot of great research in neuropsych. And if you look at research as a way of accumulated experience, so to speak, observation, the fact that you can have control groups, comparison groups, 4 cells of a covariation table, single and double blinding, quantification where helpful, those are powerful, brilliant.
Absolutely.
Epistemological, methodological advantages. I think it's important to appreciate this is not negative commentary on the human brain. Complex data integration, and there are hundreds of studies on this, is very, very, very difficult.
Of course. In
our field. Part of the reason is we don't yet generally have potent theories. Theories are great integrators of data. Theories need 3 qualities to be good, powerful predictors, better than, say, a statistical decision rule. You have to have a good handle on virtually all the important variables that determine outcome. You have to have very accurate measuring tools, and you need a damn good theory that has what the philosophers would deem a high level of verisimilitude, truth like this. That is very hard to come by. Very hard to come by in the mental health field. Getting there in some areas, it's not a negative reflection on the brilliance of so many individuals. And then don't try to integrate all the data. A lot of the data will not help you.
Mm-hmm.
It will be counterproductive. In business, they often say, take the best variable and go with it. I'm not advising that. But very often, a small set of 2 to 3 variables for a specific decision, combined properly, or even weighted equally, will do better than this almost classic textbook example of trying to integrate all the data. Data often, because of measurement error and other things, points in opposing directions. There is measurement error. You can't integrate 2 opposing points of view properly. Go with the best. Don't add a bunch of stuff in. Try to go with validated variables, and just, it's worth considering making increased use of base rates. That's my short list.
I like it. I like it. I like a good list. And I think other folks do too. Yes. Well, I appreciate you just taking the time to get into these topics a little more deeply. I mean, it's clear that these things are important and that you have pretty extensive knowledge on an area that a lot of us, I don't want to say feel mystified by, but it sounds good in theory, maybe harder in practice to bring all this together. And so, yeah, thank you for having the conversation. And
Yeah. Sure. Jeremy, if I could just say two things. One is learning neuropsychology is harder than learning decision.
okay, that's good to know.
It is. It clearly is. And, it's there to be a helpful device, not an enemy. And it's worth considering. And
Absolutely.
it might be worth looking at the checklist. And there are many good sources on
Certainly.
decision making. I hope we've added 1% to the literature with our recent book, but there are many other good sources. And it's very interesting, I think, personally.
It is. It absolutely is. Yeah. And I would,
It's where science and practice meets.
right.
It's a really good example, in my opinion, of science practice integration. And speaking personally, I have been humbled by reading this literature many times over.
It is humbling.
I've benefited.
Yes. Yes. Well, I know that your book does add more than 1%, I'm sure. And we'll encourage people to check it out. We'll list it in the show notes for sure. And yeah, engage in a practice that's going to benefit us and our clients as much as possible. So it was great to connect with you.
Thank you so much, Jeremy. It's an honor and a pleasure speaking with you today.
Likewise. Likewise. All right, y'all. Thank you so much for tuning into this episode. Always grateful to have you here. I hope that you take away some information that you can implement in your practice and in your life. Any resources that we mentioned during the episode will be listed in the show notes, so make sure to check those out. If you like what you hear on the podcast, I would be so grateful if you left a review on iTunes or Spotify or wherever you listen to your podcasts. And if you're a practice owner or aspiring practice owner, I'd invite you to check out the Testing Psychologist mastermind groups. I have mastermind groups at every stage of practice development, beginner, intermediate, and advanced. We have homework, we have accountability, we have support, we have resources. These groups are amazing. We do a lot of work and a lot of connecting. If that sounds interesting to you, you can check out the details at thetestingpsychologist.com/consulting. You can sign up for a pre-group phone call and we will chat and figure out if a group could be a good fit for you. Thanks so much. The information contained in this podcast and on the Testing Psychologist website are intended for informational and educational purposes only. Nothing in this podcast or on the website is intended to be a substitute for professional psychological, psychiatric, or medical advice, diagnosis, or treatment. Please note that no doctor-patient relationship is formed here, and similarly, no supervisory or consultative relationship is formed between the host or guests of this podcast and listeners of this podcast. If you need the qualified advice of any mental health practitioner or medical provider, please seek one in your area. Similarly, if you need supervision on clinical matters, please find a supervisor with an expertise that fits your needs.